Okay, well, I just wanted to do kind of a brief overview of assessment, kind of introduce some ideas, things for you to think about, and a quick down and dirty introduction to some of the disease process, just kind of a broad overview of some of the disease process topics related to cardiovascular. So when you consider assessment, you want to think initially kind of think globally. What are some of the questions that I might need to ask that would impact a patient's cardiovascular health? So, you want to assess for what do they think is going on? What is the problem that brought them in? That might indicate a cardiovascular problem. Look at their past history. Do they have a history of hypertension or peripheral artery disease or diabetes? And so you have to think, well, why diabetes? What does diabetes have to do with cardiovascular system? Renal failure. What does that have to do with the cardiovascular system? But these are the kind of things that we need to know about. Family history, lifestyle. Do they drink a lot? Do they smoke a lot? What is their gender, their work level, their stress level? Have they, what kind of changes have they noticed? Fatigue, hair loss, sensitivity to heat and cold, wounds that are slow to heal, changes in vision, different kinds of things that might indicate that they are having a cardiovascular problem. You want to know what is normal so that when you are assessing, you understand quickly that something is not normal. Now this is showing the 5 P's, but there's actually 6 P's, and the 6th P that's not listed here is poikilothermia. And that's just kind of a fun word. It's spelled P-O-I-K-I-L-O, thermia. So poikilothermia is an inability to maintain the body temperature. Now we're not talking about general body temperature here. We're talking about a specific area. So that area experiences coolness because it doesn't have adequate arterial blood flow. And without adequate blood flow, then it can't maintain heat. As a general rule, that area would probably be pale, or it might appear cyanotic, depending on the severity of the lack of arterial blood flow. Now, pain can include the numbness, or not numbness, but pins and needles, tingling sensation that people experience from decreased blood flow, the cramping that's experienced or aching when up and moving around when the patient has peripheral artery disease. It can include the pain of angina, the pain of myocardial infarction. So, of course, we're going to assess pain for lots of reasons, but we need to understand the location of the pain can be an indicator of cardiovascular disease. Pulse, we're going to, of course, check the apical pulse. Is it regular? Is it irregular? Is it strong? Is it weak? Is it distant? Does the peripheral pulse match the apical pulse? Do the peripheral pulses match each other? Where do I locate peripheral pulses? Did I have to work my way up the body before I finally found one? And then what are the associated symptoms that go along with that? And what am I going to do about it? If we're pulseless, that usually means lack of arterial blood flow. And so what do I want to do if an extremity has lack of arterial blood flow? How can I help that along? Pallor, again, is usually an indicator of lack of arterial blood flow. There's just no fresh oxygenated blood. going in there. There's a blockage somewhere. Again, poikilothermia will probably be associated with that. Paresthesia, when they experience numbness, usually of the lower extremities, but can be the hands, as a result of changes in peripheral circulation. And then, if it goes on long enough, it can actually affect the motor function of that limb because of the impact on the nerves that lack of blood flow has, and so they can get to where they have difficulty moving parts of their body. This slide is just showing the different areas of that you can listen for different problems with heart sounds. Primarily, your expectation is that you'll hear S1 and S2, lub-dub. But if you hear something different, then you might find that listening in different areas helps you hear that sound better. Sometimes you're going to hear a murmur perhaps in one area that you don't hear in another. Lub may be louder in one area and quieter in a different area, just based on location. If you remember, the heart sounds that you hear are because of the closure of the valves. So when we hear lub, it's because the aortic and pulmonic valves have closed. I think that's... Now I've got myself confused. Give me just a second. Yeah, no, I knew I was wrong. S1, which is lub, is closure of the tricuspid and the mitral valves. So think about what has occurred to close the tricuspid and the mitral valves. These two valves are between the atria and the ventricles. So that means the ventricles have contracted. So when I hear lub, that means the ventricles have contracted and shot blood through the aorta and the pulmonary artery. When I hear dub, then that means that the ventricles have relaxed and the aortic and pulmonic valves have closed because of backflow from the aorta and the pulmonary artery. If I hear extra noises, such as an S3 or S4, and it's not really important that you are able to recognize them now for what they are or what they mean. Just know that if you hear an S3 or an S4, meaning you hear a different sound, an additional sound, such as lub-dubby or beloved dub, then that might, in anyone over the age of 40, that typically indicates a cardiovascular problem. Those extra sounds are sometimes normal in people under the age of 20. So just spend some time listening in different areas, just to get used to, kind of what it sounds like, so that when you do hear something abnormal, you're more in tune to it. Now, heart murmurs, you will usually, you're not going to hear them very often, but sometimes you will on a newborn, or someone has a functional murmur that they've been living with forever. But murmurs can occur because of stenosis of a valve, meaning the valve has gotten stiff and it's always open a little bit, so blood is flowing back and forth, going in the wrong direction. It could be a partial obstruction of a vessel. It could be an aneurysm, which is a ballooning out of a vessel. And so, the cause of the sound that we're getting, regardless of where it's at, is because the turbulence of the blood, and that's causing a vibration that we're hearing as this sound. So anytime we have a valve that becomes floppy or stenosed, it doesn't close all the way, then we're going to hear some type of murmur. We might also hear a murmur if there's a septal defect. And the septum is the area that divides the heart into left and right sides. So we could have a hole between the two ventricles or a hole between the two atria. And sometimes this doesn't cause a problem. It's too small, or there's not enough pressure to cause blood to flow in the wrong direction. But sometimes it is big enough that we get a mixing of oxygenated and deoxygenated blood, perhaps causing less oxygenated blood than we desire to flow into the body, and so then we end up having an oxygenation problem. So again, think about what is not just the underlying pathology, but what is the end result of that. And I think when we talk about some of the other disorders, then you can come back to this and you can figure it out. So we know that the valves are supposed to close completely to allow blood flow to be one directional. And it's when something happens like a septal defect or a problem with a valve and blood flow becomes multi-directional, or it's reversed, then we begin to have problems. I don't really want you to worry too much about the different types of murmurs as far as systolic and diastolic. At this point, recognition of a murmur and thinking about the consequence to the patient. What does that mean for cardiac output? What does that mean in terms of patient symptoms? What does that mean in terms of nursing interventions is what I really want you to think about. So here's just a nice little picture page that kind of goes through a head to toe, giving you things to think about for each area that could indicate problems with the cardiovascular system. So brittle dry hair, changes in the eyes can cause can be caused by hypertension. Yellow raised dots on the inside of the eyelids can indicate high cholesterol. Jugular vein distension can be an indicator of heart failure. Distant heart sounds can indicate pericarditis. Lung sounds can indicate left-sided heart failure if they sound moist. Multiple readings of high blood pressure, fluid accumulation in the abdomen, skin changes, skin breakdown, clubbing, which we've talked about before, absence of hair, edema, changes in pulses. So all of these things are assessment findings, but you want to ask yourself why. Why would I have a decreased sensation of the feet? Why would I have edema? Why do I have absence of hair? Why do I have clubbing? Why does abdominal fluid accumulation indicate heart disease? Why does crackles indicate heart disease? Crackles may not indicate pathology with the lungs at all. And so we need to be able to pick up other clues that lead us in the right direction. Diagnostic tests, I'm not going to spend a lot of time on. I think the learning activity will help you to determine, but these are some of the ones that you might want to take a quick look at. Of course, cholesterol and blood lipids. We know that elevation of those leads to atherosclerosis. It's a simple blood test, and medications can help control it. Electrolytes. What are electrolytes? So we're looking at sodium, potassium, calcium. And so what? What do electrolytes have to do with cardiovascular health? Well, remember when we talked about in pharm some of these electrolytes, that potassium especially has a huge impact on cardiac conductivity, rate and rhythm. And sodium and calcium can affect the heart as well. What am I going to see if I have an electrolyte imbalance? Blood glucose. Well, again, I asked earlier, what does diabetes have to do with blood glucose or cardiovascular disease? So that, there's a tie-in there. What is an angiogram? What kind of patient teaching would I need? What prep does the patient need? What are the nursing expectations before and after? So that's the kind of thing you want to look at for all of these. I don't know, I have serum lipids on there twice. Coagulation studies, AST, C-reactive protein, angiogram I have on there again. I wasn't paying much attention apparently. Cardiac enzymes. Those are some of the things that you want to maybe take a quick look at least before coming to class, and be able to locate them quickly as you participate in the activity. A couple of things about disease processes. Coronary artery disease. Now, if you've watched the A&P, then you remember that the coronary arteries is what supplies the heart muscle, the myocardium, with its oxygen and nutrients. If we have a blockage or a partial blockage or a spasm, then that means that distal portion of that artery doesn't get blood flow, and it means that that portion of the heart muscle is ischemic, and if it's prolonged, then it becomes necrotic. And the difference between angina and MI is that with angina, it's an ischemia, just a decrease in blood flow. With an MI, we have a complete lack of blood flow, complete lack of oxygenation, and we get necrosis or tissue death. What I want you to consider is, what does that mean to the function of the heart if that tissue dies? And so then you have to ask yourself, well, what is the primary function of the heart, and how does that tissue death keep the heart from doing its job? So you kind of have to put that together. Think about what symptoms you're going to see, what medical interventions you would anticipate, and what nursing interventions you can do, as well as diagnostics. You remember, we're bringing more stuff in, so now we're kind of looking at meds together, diagnostics, looking at along with all of our other nursing process items, because your diagnostics are part of your assessment. Meds are part of your assessment because they can be a treatment or they can be a cause of the problem even. Cardiac dysrhythmias, so if we see a disturbance or irregularity in the electrical system of the heart. The primary problem with dysrhythmias is sometimes they're life-threatening, and sometimes, they decrease cardiac output, which in the long term could also be life-threatening. What I want you to think about is, I don't want you to concern yourself, well, what do they look like on a strip, or what would they sound like, but what would your patient report? What would you observe if a patient was in VTAC, if a patient was in VFib, or if they were asystole? So, ventricular tachycardia, we're talking rates well over 150, 200. So it's going very fast. And again, so if you think back to the function of the heart, how does the ventricles beating so fast impair the function of the heart and threaten someone's life? Now, ventricular fibrillation is different than tachycardia in that instead of getting a full contraction each time, it's just kind of jiggly like jello. There's no symmetry to it. It's just kind of moving in waves. And so again, you can see, if you think about it, exactly why that's life-threatening. Because once you realize what the problem is, what is not occurring with VTAC or VFib, then you understand. And then asystole means no activity of the heart. It's not doing anything. And again, you can see why that's life-threatening. Decrease in cardiac output can occur with severe bradycardia. We're talking, heart rate in the 30s and 40s. That's going to be some, if you think back to cardiac output and what's causing cardiac, what adds up to cardiac output? Well, stroke volume and heart rate. Well, we can't really change stroke volume, and so when the heart rate goes down, stroke volume stays the same, then cardiac output is going to be decreased. Atrial flutter and atrial fibrillation contribute to decreased cardiac output. So again, we have the chambers that aren't contracting completely. A complete heart block means that somewhere along the route that the electrical current goes, it's being stopped. And depending on where that stop is, that part of the heart is not going to contract, and so not as much blood is going to be circulated. And then PVCs, which are premature ventricular contractions, decrease cardiac output because the ventricles contract out of sequence, and so fill time is changed. So when they contract in sequence, not as much blood is circulated. So again, we have decreased cardiac output. Cardiomyopathy means overgrowth of the cardiac muscle, the muscle of the heart. So you can see that there's three types. Dilated, meaning that the ventricles are enlarged. The problem here is that the heart is kind of floppy. It doesn't have any tone, and so it doesn't contract well. In restrictive, it's kind of the opposite in that the heart muscle is stiff, and so again it doesn't contract well. And you can see that it's overgrown a bit, and so the volume that the ventricles hold is diminished. And then in hypertrophic cardiomyopathy, again the muscle has overgrown, and you can see that the ventricular space is severely limited. So again, the end result of all of these is that we have a change in cardiac output. We've got change in blood flow, and all of these things are going to lead to the symptoms that we end up seeing. Heart failure is caused by disorders that make the heart work harder or that interfere with the pumping ability of the heart. These are classified as systolic, meaning that the ventricles are ineffective pumps, because remember, your systolic pressure is when the heart is pumping, or diastolic, meaning when the ventricles relax, blood is not coming in for whatever reason. The bottom line is, whatever the cause is, cardiac output suffers. Typically, you can think of heart failure as right-sided or left-sided. And if it's left-sided, then what's going to happen? Remember that blood flows one direction. Well, if the heart becomes that inefficient pump, then its blood isn't flowing in the direction it's supposed to, and it's going to begin to back up. So the left side of the heart is going to back up into the lungs, and the right side, heart failure, is going to back up into the body. So hopefully at this point you've made the connection that the reason that abdominal fluid or an enlarged liver can indicate heart failure is because of the backup of the blood. And so what happens when blood backs up and becomes stagnant? Well, it allows fluid to leak out of those vessels and into the surrounding tissue. Remember that the liver has a good blood supply, and if it's backing up in that liver is going to become edematous. Ascites, which is the abdominal fluid, is just another form of edema. It's just the fluid is trapped in the abdominal cavity. We can have inflammatory cardiac disorders. The valves can be inflamed. The muscle can be inflamed. And it's not actually the valves, it's the lining on the inside of the heart. Or the lining on the outside of the heart can be inflamed. And again, if you think about it, if there's growth on one of the valves, what is that going to do to the function of the valve? Well, it's going to impede it, so it either doesn't close all the way or it doesn't open all the way, and that's going to alter the blood flow, which is then going to alter the cardiac output, and so we're going to see all these problems. With pericarditis, when we get inflammation or fluid buildup in the pericardial sac, think about how that is going to alter cardiac output. So I want you to answer that question. Think about that. Describe to me how the inflammation or fluid buildup in the pericardial sac alters cardiac output. What does it do that changes our cardiac output? And bring that with you on Monday. Valvular heart disease, besides growing stuff, as in endocarditis, we can also have stenosis, which is stiffening, regurgitation or insufficiency, meaning the valve is kind of floppy. What happens then is that we have changes in pressure within the different chambers of the heart. So this can cause a chamber to dilate or to thicken, depending on where the defect is occurring. Congestive heart failure is a consequence of valvular disease if left untreated, and I think again you can trace it backwards and figure out why we would end up with heart failure. Dysrhythmias are also a frequent complication of valvular disease. Now these pictures, the top right is showing that we've got a problem with the mitral valve. So blood is not flowing through it, which would tell us that it's stenosed or there's some kind of resistance, which means that blood is going to back up into the left atrium and then eventually into the pulmonary system. The bottom right shows us again the mitral valve, and here we see that blood is backing up into, so we've got some regurgitation telling us that the mitral valve is not closing, and it's going to be the same result. We're going to get backward pressure into the left atrium and back through the lungs. Now, eventually you see that backs up into the pulmonary artery and eventually will cause increased pressures in the right atrium or right ventricle, and then it just progresses from there. In the upper left picture, you can see that here we have a problem with the aortic valve, and the lower left is a picture of the aortic valve as well. So you can see again the changes in pressure that are going to occur. Peripheral vascular disease, a lot of times is associated with atherosclerosis, when we cause a narrowing of the passageway. So it's often associated with hypertension as well. So hypertension can be caused by having too much fluid volume going through normal sized vessels. Again, too much resistance is going to raise the blood pressure. Or we can have normal blood flow through constricted vessels, which again is going to cause high blood pressure. We can have an aneurysm, again, which is that outpouching or ballooning of an area of an artery. And many people probably have aneurysms that don't ever cause them any problems, but occasionally we'll have an aneurysm that bursts, and depending on where it's at, say the aortic arch, can be immediately life-threatening. So again, that was just a brief overview, and stimulate some thinking, prior to coming to class. So I hope it was helpful. See you Monday.